The first session is a couple of terrific translational talks, and the first one is by Heidi Rehn. I'm happy to introduce her. Heidi is the Chief Lab Director for the Lab of Molecular Medicine at Partners, Center for Personalized Genetic Medicine at Harvard. She was recruited there from around 2001, has been building a translational genetic medicine center. Her specific interests are in cardiomyopathy and hearing loss and Usher syndrome. And she directs the clinical molecular genetics training program at Harvard. So we're delighted for Dr. Rehn to speak to us.
Thank you. It's a great pleasure to be here and to talk to you about some of the work that we're doing both in the clinical space and translational space. Let's see. Just a few disclosures. I am an employee of Partners Healthcare, which owns Gene Insight, that I will talk about, some software that we've developed, and I have several advisory relationships. So I work at Partners Healthcare, and just to give you a sense of the environment that I'm in, this is a large healthcare network of many different hospitals, the two founding hospitals being Brigham and Women's Hospital and Mass General Hospital. And we focus on patient care, teaching, research, much your typical academic medical center. But a number of years ago, Partners made a decision to invest heavily in the infrastructure to support genetics entering medicine. And that's when the Partners Center for Personalized Genetic Medicine was first conceived and began building it in 2001. And a component of that new center was to build a clinical lab, which we call the Laboratory for Molecular Medicine. And that's what I've mainly been working on building since 2003 when we opened for business. And this is a CLIA-certified molecular diagnostic lab, and we offer over 150 tests. Main areas of focus for us are cardiovascular disease, cancer, hearing loss, pharmacogenetics, and a number of different genetic syndromes we do testing for. About a quarter of our business is from within the Partners Healthcare system, but about 75% is outside, and we actually do a lot of business from Canada. Our main focus really is in large multi-gene panel testing using sequencing technologies. We started in 2003 with Sanger-based testing, and a few years later utilized oligohybridization-based chip-based sequencing, and now have converted all of those large tests onto next-gen sequencing. We do use a number of other technologies when appropriate for certain genetic tests, but our main focus is really large-scale sequencing. And our latest effort has been in developing a whole genome sequencing interpretation pipeline, which will launch this year. So I'll talk to you about a number of these different activities that we've been involved in. But I think one thing to put this field into context, and anyone can go to the GeneTest website and download this figure, and really showing the growth of the number of diseases for which genetic testing is available. And that's been a linear growth, a little steeper over the years. But I think what's not captured in this growth chart is really the content of each of those disease tests. You know, when we all started in this business early on, we were doing targeted genotyping tests for known mutations that had already been described. And then those moved on to single gene sequencing tests. And then we started growing the size of each of those tests, particularly focusing on disorders with a lot of genetic heterogeneity, to 10, now up to 100 different genes for a single disease, or even broadening to very broad panels covering multiple disease in different areas, whether it be developmental delay or cardiovascular disease, and of course bringing in cytogenomic arrays and whole exome sequencing, and now you can get, in a CLIA-certified manner, your whole genome sequenced for $7,500. So the world has changed in terms of the content, and this is a logarithmic scale looking at the number of structured results per test. And that has, of course, been driven by a dramatic a drop in the cost of sequencing, fueled by many of the technologies that are coming onto the market. So that's great. We can now test lots of more content, but is this beneficial? You know, what is the benefit for expanding disease testing to large panels or even whole exome or genome sequencing? Well, just to give you a couple of clinical examples, we started offering hypertrophic cardiomyopathy testing back in 2004. And at that point, we were testing just the most common genes involved. And we gradually developed panels that you would reflex to one after the other if they were negative. We had a test for the GLA gene for Fabry disease, knowing, because it had been well established that patients can present with hypertrophic cardiomyopathy phenotypes. However, no one ever ordered the test unless they had Fabry disease. So it was not a very highly utilized test in this space. However, when we put everything onto our HCM CardioChip, the test that preceded our next-gen panel, we included this gene that no one ever tested for, and lo and behold, there was a 2%, nearly 2% hit rate, not high, but the significance of this is it's the only gene on that panel for which there's a treatment for the disease, and you can actually regress symptoms. And so these are just a few of the many families that have been tested and mutations identified in patients who thought they had hypertrophic cardiomyopathy, but in fact had a cardiovascular specific phenotype of Fabry disease. And so these patients have been started on enzyme replacement therapy, and now we can predict the onset in their children, and they're being considered for prophylactic enzyme replacement therapy. So, this is an example, really the kinds of examples we want to achieve in genetic testing is making a difference for the patient in terms of outcomes once we diagnose their etiology. But it was never a focus until we included that in a broad, expanded panel, as it wasn't perceived to be a common cause of the disease. Another example, our AutoChip test that preceded our current next-gen panel, where we've been testing for causes of hearing loss. And in this case, we used to have the different genes for non-syndromic hearing loss separate from those genes for Usher syndrome, which is a syndrome involving congenital hearing loss and then later onset of retinitis pigmentosa that leads to vision loss. And no one ever tested for the Usher genes unless the patient actually had a diagnosis of Usher syndrome. But when we put these all together in our AutoChip test, in fact, 8% of children who thought they had non-syndromic hearing loss, in fact, tested positive for an Usher gene mutation. And that's very useful information in terms of managing the hearing loss. Obviously, the choice to use sign language, which requires visual input, is not a good choice if you're going to lose your vision. Figuring out whether a cochlear implant or hearing aids, some of those decisions are impacted by knowing the etiology of hearing loss. So this is another example where it's been very beneficial to be able to group large numbers of genes, some of which have lower hit rates, together to enable better diagnoses. So that's great. More the merrier, put them all in. So what's the drawback of doing this? Well, today, although next-gen sequencing has really opened the doors in terms of looking at more content, it's still not a perfect technology, and any of you have used it, recognize that there are challenges there. And because there's a false positive rate, because there's fallout within the test, a lot of us in the clinical world always do confirmatory testing for any variants that we find in a diagnostic context to rule out false positives, which are still occurring. And we also, for a lot of the targeted tests, will fill in any missing regions that have dropped out during next-gen sequencing. So this is our first test that we launched on next-gen sequencing, the pan-cardiomyopathy test, and we were able to take all of our different panels, so the hypertrophic cardiomyopathy, the dilated, arrhythmogenic, left ventricular non-compaction, restrictive, CVPT, all of these different cardiomyopathy phenotypes, put them all into one test, add all the genes in red, now that we had really almost unlimited capacity for putting genes in the panel. And that includes Titan, the largest coding sequence in the entire genome, which is about equivalent to the size of all the other genes combined. It's a monster. So this test was created on the using Agilent SureSelect capture and on the Illumina HiSeq. And so we run this test. We actually offer it either as the full test or to reduce the numbers of variants of unknown significance. You can order just those genes associated with a particular phenotype if you know your phenotype in your patient. And we use the next-gen sequencing using short read alignment, shown here a variant. The challenge is even a test like this, which has been well developed and validated and has very good coverage, shown here, on average 120-fold coverage across all of the regions, there's still areas that drop out and have not enough coverage to accurately sequence those regions. And so really when and this is actually a figure. So for this particular test, there's about 550 amplicons if you were to do that by traditional Sanger sequencing. So when we do the test, we actually confirm all of the variants, any bases that were uncallable by the algorithm, we repeat by Sanger, any sporadically failed regions we repeat, and then there's some recurrent regions that just don't capture well, usually GC-rich issues. So you can see for each of these 80 different samples that were part of our first validation batch, ignoring a couple of failed samples, on average, there's about 65 amplicons of Sanger sequencing we have to do to fill in and confirm everything in this test. So it still is a labor-intensive test to be able to offer in a clinical setting. And I really view this as not one test, but 239,000 tests, because you really are following up every base at some level independently and doing an iterative Sanger sequencing follow-up process to confirm and fill in anything there. So it still is a technical challenge if you really want to offer a high-quality test, and that does make it difficult. And in fact, to make sure you have robust turnaround times when you launch a test, you really need to upfront launch and develop all of those companion Sanger assays. And so our Oto genome test, which is replacing our Oto chip test, we launched the first version of it that replicated the 19 genes from the Oto chip, but we're still in development of the 50 additional genes that are added in this next-gen test to be able to do the quick Sanger confirmation of everything that drops out. So that's over 1,000 amplicons of Sanger development that go along with this sort of test development. At some point, I hope we get away from the Sanger confirmation and fill-in process, but the technology still really isn't there yet to be able to do that. So this does create a challenge, although we're going to be launching this test shortly. The rest of it. We do a lot of validation in terms of detection of different types of mutations. This is the same data set shown here for the Oto genome test. And for the version 1, we have about 13 amplicons of Sanger sequencing follow-up per test. And now we are actually in the process of validating copy number variant detection. We've been able to develop an algorithm using read depth as a indicator of copy number changes and have been detecting these in our patients, which really increases the sensitivity of diagnostic testing when you're able to include those, particularly for a recessive disease for which deletions are often very common, like hearing loss. The other challenge in adding lots of content is not only are there technical challenges I described, but the number of variants you find through testing is dramatic, and we track the number of novel variant assessments we do each month. And when we launched our first next-gen panel, that number went off the roof in terms of the number of variant assessments. And we spend a lot of time trying to assess variants and their significance. Each variant gets classified with respect to pathogenic, likely pathogenic, unknown significance, likely benign, or benign. And we've been timing our fellows how long it takes per variant to get because there's just so many resources needed to support this process. So if there's a variant out there with no data, we're basically searching many different databases, looking for data in the literature, doing in silico assessments, and then we do an evidence-based classification. So if there's no data, it takes 22 minutes per variant just to go through all those processes to look for data. 25 minutes if there's data in dbSNP or the ESP cohort. And then if there's any publications on that data, on average, it takes about 2 hours per variant to go through all that literature and make a decision on the significance of that variant. That's just the time for the fellows who do the first leg of the work. Then our genetic counselors review that data, draft the reports. The geneticists review that data again, make the final classification, and sign out the case. And then for our somatic cancer testing, a pathologist also looks at that data for clinical correlation. So it's a very labor-intensive process, and as you scale the number of variants, you're finding it really, really makes it challenging to operate in this space, and you have to have a lot of staff doing this. And it doesn't end even if you've tested a lot of patients. I've been tracking for hypertrophic cardiomyopathy. Over the years, we've increased the number of patients cumulatively that we've tested. This graph goes out to 2010. I've continued this data out. It continues to mirror. So even after testing 2,000 patients, if you look at the percent of the variants that are novel, and the blue line is clinically significant variants, you level out here for HCM. About 17% of the variants are still novel, even after you've tested thousands of patients. The data from Myriad that I saw on another slide was they've tested over 150,000 patients for BRCA1 and 2 and detect about 10 to 20 new missense variants each week, despite that amount of testing. So we really haven't tapped into the amount of genetic variation in our population at any even basic level. You can look at that data in a slightly different way. If we look at all the clinically significant variants we've found in just one disease, hypertrophic cardiomyopathy in this case, having tested 3,000 patients, 66% of the variants that are clinically significant we've only ever seen in one family. So you can't wait for the literature to publish your mutation and tell you what it is. You have to have ways to figure this out on the fly during clinical testing. There are some mutations that you see recurrently, but the vast majority of them are often unique to families. It's even worse in hearing loss. About 80% of the mutations that we've seen to date are unique, and that's probably because of the difference between dominant and recessive disorders, where there's a lot more ways to mess up and make a loss of function variant. So this creates huge challenges for just dealing with this constant number of novel variants and how you assess them and make sense of them. And that requires a lot of both manual label as well as IT infrastructure. And we've been really focusing a lot of energy in developing IT infrastructure to make this process more efficient. And the world is changing in terms of genetic technologies. In the past, really, most of your energy was on the technologies with a limited portion involved in clinical interpretation. The reimbursement, at least in the US, was even more disparaging. The reimbursement for the interpretation is like $12, and most of your money comes in the technology piece in terms of reimbursement from insurance companies. But now, this is where we are really today with next-gen sequencing. A component is the technology, a big component is bioinformatics and data processing. And then the other component is clinical interpretation. And there's not great infrastructure that really supports this. We made the decision early on that we would focus on this piece, figuring that a lot of companies would be able to deal with this space in terms of genetic laboratory information management systems, but that this was going to continue to be the challenge. And that's where we've really worked to date and been building this software system called Gene Insight. And Gene Insight really starts once you've confirm the variants that you found in your patient. And the variants flow in, the variant assessments that we do through novel variant assessment come in, and we really maintain a knowledge base on diseases, genes, variants, all the cases we've ever tested, the test definitions, references, all are in here. And then we build a rules-based templating system that draws on all of that knowledge and automatically drafts reports in rich ways. And then we also have this new module called Gene Insight Clinic that can deliver electronic profiles to patients and update them over time. And I'll show you some of that infrastructure. So we embed this database within our next-gen sequencing workflow because we want to confirm variants that are clinically relevant, but we don't want to spend our time confirming all of the benign and likely benign variants. So by interfacing our database into our next-gen pipeline, we can have an automated system that's only confirming those clinically relevant variants, and then eventually reporting out through Gene Insight Clinic. This is just a snapshot of some of the infrastructure where we maintain knowledge on each of the variants and an approval process for their clinical relevance and the evidence for them. This is just a snapshot of the templating system where we can build templates, and we usually have about 5 to 10 per disease area that basically can cover all possible iterations of content that might come out of patient, even dealing with novel variants. Once we classify them and have basic structured data in terms of their impact, missense, nonsense, frame shift, all those things, we can then use rules-based templating to say, if you see a variant like this, if you see a set of variants, if the patient has this indication, if this test was tested, all these different parameters and rules to essentially then guide the incorporation of certain text and statements. And these can get very complex, where every piece of colored text is driven by a different rule that's allowing a report to be built. And in the end, you get out an auto-drafted report with a computer-generated overall result. All the variants are structured with their classifications. There's an interpretive summary that looks at all the variants, figures out what's clinically relevant in the patient, and summarizes that evidence, puts in the recommendations based upon the variants there, and then has individual variant interpretations that shows the evidence for each of the variants, and that continues down for the number of variants. And trying to bring all of these complexities together for these large, complex tests is challenging, but we've been able to create this rules-based templating system to be able to do this fairly in an automated way. Now, you always have the need to review literature and make judgments and put in specific text, but at least it does a lot of this stuff for you. And that's helpful to minimize the number of highly paid geneticists and professionals that you have to use in your lab to interpret all these complex results. The other challenge, a lot of these tests are only done once, but the knowledge is constantly evolving as we learn more about genetic variants. So this has been a big pain point for a lot of clinical labs. How do you update those reports over time, given that there's often no mechanism to bill for updates? And our own guidelines from the American College of Medical Genetics says that testing laboratories should make an effort to contact physicians when new knowledge is learned. Well, that's great, except that this is very difficult to do, and as I said, labor intensive. And I've been tracking how often do we make changes to variants in the course of clinical testing. And this is a paper that we just published last month, looking at the amount of times we change data. And so this is just for one disease, hypertrophic cardiomyopathy. So we had about 300 category changes over a 5-year period. So basically about 4% of reports per year for a given physician. And a lot of those we consider high alerts. So they're changing clinically significant categories here. So how do you convey this information in an efficient way to a physician? So we've developed this clinic interface to our software, and this is internet accessible, so any physician ordering tests from us can get access to one of these systems, and we've one set up here for the Fred Litwin Center. And so basically they can log in and get their patient's structured test results, and the variants are structured and linked to our own variant database, so that if I go in and make a change to a variant, in real time, thousands of reports in these systems can be updated, showing that the original category might have been unknown significance, but it's now pathogenic. And that information gets automatically put in. The physician can click on the variant. They can read the evidence by which we change that classification. They also can receive alerts through email that notifies them if one of their patients has a variant that's for which the classification has changed. We've so far rolled this out for germline disease testing. It's still unclear whether it's useful in a somatic cancer testing, but in talking to oncologists, they've wanted us to use this infrastructure for clinical trial notification. So we're thinking about ways that we can support that. But it's been very effective for us to be able to communicate without any additional resources all of this new information to patient reports. And this whole infrastructure has been the subject of a funded research study that David Bates is a PI, really looking at usability of the system from a physician perspective. Can they go in and easily use it without any training? And the Fred Litwin Center here has been one of the sites of this research study, and that we're in the process of analyzing the data in terms of the outcomes. But basically, the consensus is it is a very easy system to use, and the physicians really like it. The other thing that we're trying to do, recognizing that trying to interpret the genomes of patients is going to be very challenging as we continue to need to interpret variants, is really creating a network. One of the pieces of that network is simply to enable each lab to not have to build separate interfaces to every hospital. But in fact, we've created a network hub so that there's only one interface that needs to be built. And so we've been adding hospitals and clinics onto this system, adding labs that are using the Gene Insight software so that we can create a network. Initially, when we were building this, we had the idea that we could then hook up clinically valid knowledge bases into the system that could directly flow into a patient's chart. However, the validity of some of these systems is still not there, and what we've decided now is to sort of rework this a little bit and really facilitate and focus on lab-to-lab sharing and bringing knowledge sources into that network, as well as enabling labs to share data with each other. And more recently, there's been a number of labs that have expressed interest and willingness to share their data sets, recognizing the pain of this variant interpretation process. So We just launched the infrastructure to be able to do that within Gene Insight. So now when you're in your variant page, you can click on external info. You can see the different labs and their classifications, the basis for theirs, how many cases they've had, and if the labs are willing to share their case level data, we strip out PHI and allow them to see the actual cases. And that's often important, particularly for recessive diseases, where you want to see variants found with other variants, not just an individual variant interpretation. And in tumor testing, was it a lung tumor, a breast tumor? What was the context in which that was seen? So we can enable case data sharing, but strip out the PHI, so there's no identification there. So this enhancement will be launched next month into the system and will really enable this data sharing environment. And labs can choose to share data or not. They can share data specifically on certain genes or all genes, on cases or variants or both. There's a lot of flexibility there. But the idea is to really encourage data sharing so that we can all benefit from that. And that's dealing with this major problem that in the public environment, there's not enough data. Most of the data that's there is unannotated in databases like dbSNP and ESP, which is useful for control populations, but still there's a lot of pathogenic variants in controls, having looked at a lot of that data. The data that is annotated in the public in locus-specific databases often is usually from initial research studies with small populations, and in fact, a lot of it is wrong, and a lot of the variants said to be pathogenic are in fact benign. And this is just one study showing that over a quarter of that data is wrong, and there's many others. So where the real higher quality data sits is often in the clinical labs that have been doing thousands and thousands of patients worth of testing after the original discoveries. But unfortunately, that data doesn't get in the public domain easily. And so we've been working on a grant proposal to actually bring all this data out of the clinical labs and submit it into the public domain. We're applying for a U41 genomic resource grant called a Unified Clinical Genomic Database. And there's a lot of people, mainly in US clinical labs, that are the initial start of this, but we've also now been branching out into international collaboration to support this. Some of the basis for the approaches we're taking is based upon the work of the ISCA, the Cytogenomic Array Consortium, where they've been doing this for CNVs and getting lots of data out of clinical labs, and it's gone into the NCBI DBVAR database and dbGaP. So we're using a lot of the infrastructure that they've developed and the approaches to really extend this into the sequencing space. And in going out and reaching out to many of the laboratories, lots of people have agreed to support this effort and share their data. We've got specific commitment of over 160,000 cases worth of data to be submitted into this system for this grant, and we're continuing to reach out to other labs. And the idea here is the first phase of this is actually to create better standards. We don't have great standards in this space. People call variants lots of different terminologies. The only thing I think we all agree on is the term variant of unknown significance. The rest is still open for debate in terms of what terms are used. But the goal is to collect a lot of data, both from curated clinical lab data, data that's out there already, as well as the uncurated population data that's coming in from various studies, but then put it all into one place and really enable expert curation of that data to arrive at a clinical grade variant database for that the whole community can use. We're working closely with NCBI to utilize this new ClinVar database that they're developing, which will have variant clinical annotations on it, largely provided by the clinical labs working with them. Full case data can go into dbGaP, which is a protected environment, but the actual variants will be fully in the public domain in ClinVar, and they'll be accessioned jointly into dbSNP and dbVAR, but the clinical annotations will sit in ClinVar. And we're working with a lot of other groups and other efforts, Mutadatabase, OMIM, Gene Reviews, locus-specific databases, and the Human Variome Project, working with vendors to help create efficient solutions for labs getting data into this space, and then expert teams on the data curation end. So, as I mentioned, the issues with terminologies is a continual challenge. And the way we anticipate having this data marked in ClinVar is at different levels of curation. There was some discussion about, well, let's create a separate database for the high grade, quality data, and then the low grade will be another place. Well, every variant is on a continuum in my mind, and so trying to separate these into two spaces, it just adds yet another database for me to search. So the idea is put it all in one space, but mark it. Some of the data just won't be curated, but it'll be there for population frequency basis. Labs that are submitting their own interpretations will be marked as a single source curation. And then we will enable the expert curation of consensus-driven, evidence-based examination of those variants with multiple sources of data, and then we can mark that expert curated. And then there'll be a small subset of variants that are actually in practice guidelines that will be marked as such. But this enables one place for everything to be in. You can use the different levels of information depending on the quality that you need to achieve. So that's the goal of this grant. It was actually submitted and reviewed. We had a marginal review the first round, partly because no one with clinical genetics expertise was reviewing the grant, but we are going to address the critiques. We're submitting it again in about 5 weeks. It'll be due, and from the feedback we've had, I think there's a good chance it'll get funded, and I think this will enable a lot of community effort to bring this data into a common place. So we look forward to that, and I think, our prediction is within about 4 years, all of this targeted testing will transition to whole genome and exome approaches, and so we've got to be prepared for that, and we're in the process right now of launching our whole genome sequencing interpretation service, working really closely with our genetics clinics to enable the case selection and consent process. Initially, we're actually outsourcing the genome sequencing to Illumina and focusing initially on the data analysis piece and how we're going to enrich and filter that data. So we've been building pipelines for that, as well as what data we'll report. We intend to report both the disease-specific etiologies that we identify, as well as secondary findings in a general genome report. And we're working closely with a funded grant, the MedSeq grant, where we have a clinical trial for whole genome sequencing, and a lot of that is to develop better secondary findings reports through that effort. So that is a collaborative effort right now in terms of getting these reports built and back to patients, and then supporting structured data in the EHR so that can be leveraged for clinical decision support. We have 3 cases that are underway right now, and just to illustrate the challenges in this space, the first case we worked on, we thought this was going to be an easy case, family with a clearly genetic form of hearing loss, 5 affected children, a unique sort of form of the hearing loss, though the initial whole genome sequencing that we performed on 3 of the children yielded no obvious candidates. Then we dug a little bit deeper into the phenotype. It turns out that the paternal grandfather actually has this very similar hearing loss. And so then we thought, well, maybe this is actually a dominant form of hearing loss with reduced penetrance, and that's why dad is unaffected. And so we then ended up sending the whole family for SNP arrays for linkage analysis so that we could narrow down the loci and look for regions that could be dominant variants. And this case has been ongoing for probably about 6 months, and we're still, not identified a candidate. And that's challenging, because the biggest challenge is, when do you stop? When are you going to exhaust the 3 million variants that are in that patient that are potential candidates? And that's the biggest challenge, I think, in launching a service, is figuring out when to stop on these cases. Easier cases are ones where you might suspect a de novo occurrence. Our second case was with a patient with distal arthrogryposis type 5, and this is a well-described phenotype, but with no known genetic etiology. There's been dominant kindreds described, as well as sporadic cases. So we anticipated with unaffected parents that this case would represent a de novo variant. And actually, within a week of getting the data back, we had 2 candidate genes. We're in the process of Sanger confirming them. One of the genes we think is the most likely etiology. The other gene has population level, not loss of function variants. We think it's probably not a critical gene. So these types of cases are a little easier to deal with, because the number of de novo variants that you find in a genome on average across the coding sequence is about 1 to 2 per genome. So you don't have as much background to filter through if your technical data is good. So some of these cases may be straightforward, other ones not so much. Our third case that's in progress is we anticipate a recessive etiology, although in this case, the patient, one of her phenotypes was lymphoma, and so she had a bone marrow transplant, so it wasn't useful to take a blood sample to send off her gene, her sequencing. So we had to get a skin biopsy, make fibroblasts so that we could culture them and send them off for whole genome sequencing, and that case is in progress. So these are just some of the early cases we're working on, that represent some of the challenges in this space. And I think I'll stop there. There's a number of people involved in a number of the different efforts, the Gene Insight team, the whole genome sequencing, our next-gen sequencing team, those involved in the U41 grant. I mentioned briefly the RISGEM study and the MedSeq project. And I'm happy to take any questions. Thank you.
For those of you in the back, there are a lot of seats in the front, so want to get going. You talked about, it sounds like it's almost artificial intelligence, putting all the data together and then generating a report. And then you talked about quality of data. So how does your computer or your people decide that a variant that was published in Cell or Science is better than, say, in more obscure subspecialty journals? And because that's what I think is one of the biggest problems, is deciphering what's quality data, especially if you're going to generate a clinical report.
Yeah, that's a great question, and that's the piece that is least automated in terms of reviewing data in papers. And we never take the conclusions of the papers. We basically just take the raw data. How many, what was the population that they looked at, the race, how many times did they find it, what were the phenotypes, and really trying to evaluate that data and draw our own conclusions, which are often very different than what has been drawn in the paper. I wouldn't say that we treat any journal differently than others, but you're looking at the data and what they've described and making a judgment on the raw data at the end of the day.
Jim?
Do you think that the rate of de novo mutation analysis or discovery in the cardiomyopathy series is partly due to the type of disease? In other words, any structural variants in those large genes are going to have a deleterious impact. Or do you see that actually in other disorders where you don't see so much structural bias, I guess, in terms of the genes which are included?
Yeah, so actually in cardiomyopathy, since it's a dominant disorder, and for most of the genes, it's more of a dominant negative mechanism, you actually see almost no structural variation or deletions. They're almost always missense variants. Now in some cases, some variants we see de novo, particularly very severe variants that are essentially genetic lethals, and we only ever see them as de novo, but actually it's not a high rate of de novo variants for cardiomyopathy. In the hearing loss, we do see these copy number variants, but they're usually a single exon or a few exons, rarely the whole gene, and those tend to be inherited and not be dominant, or sorry, not de novo. So I think where you get more de novos are more in the developmental delay field and the complexity there. So it's a slightly different sort of picture. But I think in terms of the percent that are novel, we are a young, a species, and there's still a lot of variation that is different across all of us. We all have thousands and thousands of variants that are unique to each of us, and sorting out what is actually impacting a phenotype versus what is benign is very challenging.
Question? There's still some seats in the front. Don't go anywhere yet. So I had another question about that enormous project that you're proposing at the end. And I think it's a great idea, but I don't think we need 2 or 3 of them. So is there competition to build the best database in the planet? And do we need to keep competing? I see that you have collaborators together, but I would hate to think the NIH would fund 2 or 3 of those. So is that the plan, or do you know?
They have told us that they've set aside money for this project, and if we can address the critiques of the first round, I think there's a good chance we'll get it. We are not aware of any other group that's really trying to do this at this level. Now, there are many efforts trying to get variants in locus-specific databases, or the Human Variome Project has been doing this for many years to support locus-specific databases. And I think that model was good when we all were niche operations looking at specific diseases, and you knew your specific locus-specific databases to go to, and that was useful. But now that we're all trying to do these genomic analyses, you can't go searching out to the 1,500 different locus-specific databases that exist. We have this massive table for each gene. Look at this 10 databases for this one, look at these 12 for this one, look at these. It's unmanageable. So our goal is to really work with the locus-specific groups to bring that data into a common place, to work with OMIM, who's, they've addressed a sort of exemplary set of mutations for each disease, but not meant to be comprehensive, to work with gene reviews that has collected some of these. So the Muta Database Project is a collaborative effort with ours, the ISCA Consortium. So the goal here is to bring all of these groups together as opposed to having competing projects. At the same time, as much as I would like there to be truly one, I think, you know, it is logistically just hard to harness everybody working in this space in one shot. So I think there's going to be some evolution of this process in terms of gradually moving towards. But I think through IT, you know, approaches, there's a lot of spaces where you see a single database and all the data is there, but in fact, data actually exists in multiple places and is being reflected in real time. So I think with enough sophistication, there can be multiple instances of databases if they're truly integrated appropriately to reflect those data sources.
So sounds like it's a lot of work and extensive effort to put the curation into each variant. My question would be, some of the variant might only work in conjunction with other variants, and how would that be taken into account in the curation process?
Yeah, it's a great question, and you know, we often in the disease-targeted testing, we're sort of looking for the primary etiology. But, you know, for example, in hypertrophic cardiomyopathy, about 5% of our cases have a second variant that we think is contributing to the phenotype, but isn't the primary etiology. And so, you know, really trying to understand that contributory modifier effect is very challenging when you're looking at one case at a time. And that's an environment where you really need to get a large number of cases together to really understand the contributory roles. And I think that's one of the goals in terms of getting lots of data from lots of places into a common site. So not only can you share variant interpretations, but you can amass data that I think is going to be critical for us to really understand the complexity of human genetic variation and understanding, you know, contributing low risk roles, all the modifiers, all those different types of variants. Absolutely.
Just one small question. How are you going to bring your database to the international level? I think currently your database is more restricted to North America. What about third world countries, and how will you bring this database to represent the whole human population?
Yeah, no, it won't be restricted in any way, either from a contributory standpoint or from an access standpoint. So anyone can access any of the NCBI resources from anywhere in the world, as far as I understand, with an internet connection, basically. So the goal is to make it accessible to everyone, and that was one of the rationales for working with NCBI. They have a reputation for really providing those resources. In terms of, you know, working to get data from different sources, we, you know, through the Muta Database Project, which is a European site that has interacted with a number of different international sites. We've been, you know, trying to harness interactions, working with China and Mingxi there in terms of getting data from China. There are challenges because different countries have different laws about data export and sharing, and, you know, trying to deal with different international laws is and will continue to be a challenge. But the goal is to try to continually work to make this a fully international effort.
Up there. Huh?
Yes.
Do you have a group of curators? They are looking for your specific database and the disease to right? Like I work for the curation for the LSDB. So
Yeah.
I know we are doing curation for each of them. The new SNP is submitting, we look for the phenotype and the clinical thing. So for your database, is there any curator for any of this?
Yeah, so in terms of the grant that we put in, we chose 8 different disease areas for pilot projects in terms of, and we have collected disease-specific experts in those 8 areas that include cardiomyopathies, colon cancer, developmental delay, metabolic disease, congenital muscular dystrophy. So there's a few different projects, Noonan syndrome and related syndromes, that we have focused on and in advance gathered a group of experts to work on the curation piece. And I think curation will happen in several levels. One will be a natural curation, so that if all this data is in the same place and as you're evaluating a variant, you can actually see how other groups have evaluated it, and that data is in the public domain. I think it'll actually inherently improve the curation at some level, even without organizing a specific group. So that's one level. The second level is to truly bring experts that have deep experience in these areas together to evaluate the data as an independent sort of assessment, and then mark another level of curation on top of that. So the goal is to facilitate both those, to start with these 8 pilot projects and then really expand to as many disease areas as we can. And I think working with the locus-specific groups will be one way to, interface with existing efforts.
Yes.
So I was wondering, you mentioned reimbursement very briefly. How is your vision in the future? How is that going to work out?
Well, I wouldn't say that. That's going to be an evolving process. There is reimbursement for genetic testing today, but it's all about demonstrating clinical utility. Now, it gets a little complicated as we move towards genome and exome sequencing in terms of, do you argue for the clinical utility of the reason you did the initial test, and what about the clinical utility of other data that might be gained incidentally as secondary findings? And, I'm part of a committee through ACMG looking at what secondary findings from exome and genome sequencing should be reported back to a patient. And one of the challenges in terms of looking at existing guidelines is existing guidelines really focus on, should you order a new test, a specific test, pay for it, and incur that cost in terms of what you gain from that data. In the genomic era, it's really, you've already got the data, and it's just a question of, do you want to give it back, and what's the potential upsides and downsides of giving data back that isn't an incremental cost in terms of obtaining the data, but could reflect incremental cost in terms of what happens after you get that data. And so it's a slightly different paradigm that we have to think about in terms of the value of this data and what's being given back and how that data is used, interpreted, and influencing patient care. And so I think there's going to be increasing complexity in terms of how we think about valuing this data and paying for it. And I can't say that I have solved that problem yet.
Okay, thank you very much.